So today we are gathering together to honor Maureen Strafford, who was an amazing woman and physician, advocate, and leader. For those who didn't know Maureen, she was trained as a pediatric cardiac anesthesiologist and a pain physician, who was really a champion for compassion and humane care of children in medical settings. Her interests range from the provision of safe and effective sedation for children undergoing painful procedures to postoperative pain management and using mindfulness to reduce anxiety and pain. When Maureen became ill and she could no longer do clinical work, she focused on the importance of humanism in medicine and worked with various foundations and helped establish the white coat ceremony in medical schools across the country. She brought her keen, intelligent passion, kindness, and big heart to everything she did. And I, as a personal note, I didn't know Maureen well, but every time I ever was in a room with Maureen, it was filled with laughter and a little bit of chaos as well. And I think she brought those qualities to everything she did. And this lecture was established to continue to promote her values, not just the chaos, but the other wonderful values she embodied, which are central to the work of Childkind. So today we're honored to bring Wally Smith, who is the Florence Neal Professor at Virginia Commonwealth University, to our forum today. Wally is an incredibly accomplished physician and as well as an advocate. I've known Wally for since the start of my really interest in sickle cell disease, and I've been privileged to been on a number of panels, meetings, and involved with him in a number of ways. And the remarkable thing about Wally, regardless if if he's talking to a group of physicians, patients, advocates, that when Wally speaks, everybody stops talking and everybody listens, because Wally's voice is really the one that folks want to hear. And I think you'll note his amazing command of both the literature, but the importance of recognizing the disparities of care that have been experienced by individuals with sickle cell disease, and just all he's done over his career to remove those disparities and move the field forward. So thank you, Wally, very much for joining us today. And I'm going to stop sharing my screen and allow Wally to take over.
Can everybody see that? Okay.
We're good.
Yep.
Right. Very generous introduction, and thank you, Bill. And Bill is being humble because he has carried the torch in advancing the cause of sickle cell disease for children and adults alike. Many of you are maybe aware that he wrote this article, Fostering Trust and Justice, in the Journal of the American Association, talking about how sickle cell pain is mistreated and the disparities related to that. And I refer to that article often in my talks. I want to walk you through a lot of material, but also leave some time for discussion. I'm going to make some definitions. I'm going to talk about a funnel approach, starting with non-cancer pain and how it's undertreated and under-recognized, and then how pain in minority populations is undertreated, and then narrowing it down, pain in sickle cell disease, poorly measured and poorly understood and undertreated, and the patients are misunderstood and stigmatized, and then offer the beginning of some solutions, which actually are huge, audacious goals involving science, patients, physicians, and society. If you don't already know, sickle cell disease is under-resourced, undertreated, misunderstood. These are patients who, in general, are African American in the United States. This is a pain-producing hemoglobinopathy. The sixth position of the beta chain of hemoglobin is altered, and that small molecular disease causes protein problems throughout the entire body, manifested mainly by pain but also by early death and organ failure and predilection to infection as children. There are mostly Medicaid beneficiaries in terms of who is seen with sickle cell disease. We now have seen that unlike other pain conditions such as cancer, these patients have longer wait times to see a doctor and to get pain medication when they go to the emergency department or the hospital. And the number of physicians to treat sickle cell disease, even trained oncologists, is limited. They do not see sickle cell disease, adults especially, and even children. I would say that there's a disparity there. Let me talk about some definitions. First, what is stigma? Stigma is the disapproval of or discrimination against a person perceived based on perceivable social characteristics that serve to distinguish them from other members of society. Things like culture, gender, race, and intelligence and health. What is a health disparity? Not simply a difference in health outcomes by race or ethnicity, but also a difference attributable to variables other than access to care. Examples: the richest Americans live longer than the poorest. They live longer than the middle class, and they live way longer than the poorest. Another disparity: we're one of the richest countries in the world, but we rank 38th for life expectancy, behind that of many third world nations for babies born in the 2000s. And we spend a lot of money on healthcare, but don't get our bang for the buck. Now, a healthcare disparity is a component of a health disparity resulting from the care that occurs inside the healthcare system, so that even with equal access, patients may be treated differently by physicians, nurses, and the like. So with that backdrop, let's focus on non-cancer pain. What is it? It's pain that lasts 3 or more months. Some people say 6 months. And it is common. It's 11.2% of adults with pain every day for the last 3 months. 17.6% of adults with severe pain. And then comparatively worse health as a result, more healthcare utilization, more disability, days off work. And it's difficult to measure, difficult to get disability for, difficult to get attention to because there's no tumor, there's no blood marker. Most of you know that the opioid epidemic is upon us, but even prior to the opioid epidemic in 2013, opioid prescriptions started dropping in the United States. And for example, the rate of so-called dangerous MMEs, morphine milli equivalents prescribed per day dropped 9.3% annually from 2009 to 2016. The average days of supply of prescriptions lengthened since that time, but the prescribing rate dropped by almost 5%. So even before the CDC's opioid guidelines in 2016, we saw declines in prescribing rates. Attitudes about prescribing opioids are stingy. If you look at urban versus medium versus small town physicians in this study, 30% of all of them said that opioids were only for severe intractable pain. 10% said it's only for the palliative care when people are going to live less than a year. 25% said if you give opioids long enough, they're going to cause addiction. And a significant number were concerned about federal and other scrutiny by regulatory bodies losing their license. And the small town docs were less accepting in their attitudes than the large urban docs. And the psychiatrists were more accepting in their attitude than surgeons or internists. Similarly, pain in minority populations may be underrecognized and treated disparately. This is a study of long bone fractures and showed that Hispanics were less likely to get analgesia. Here's a study of cancer showing that guideline recommended analgesics were less likely to be given to minorities, especially Hispanics, than whites. Here's another study of post-operative limb fractures showing that the morphine milliequivalents used by whites were greater than for Blacks, and even that greater than for Hispanics. And here's a study of PCA showing there's not more temptation to press the button across race, yet the prescribed PCA doses were greater for whites than Hispanics and greater for Blacks than for Hispanics. Here's a study showing that physicians were ready to underestimate the amount of pain in Blacks. It takes you back all the way to slavery when it was believed that Black people felt no pain. The disagreement rate under or over about 2 points was 77, was 39% for Blacks and 47% for whites, with physicians and 40% of patients underestimating the pain's perception, and 15% overestimating it. But no surprise, it was more often for Blacks than for whites. Pain is poorly measured, and then pain in sickle cell disease. Pain in sickle cell disease is the hallmark of the disease, ubiquitous, present throughout life as young as 6 months of age. So children with sickle cell disease present most often with pain. Most of you have seen or heard about something called hand-foot syndrome. It's variable. The genotype explains some of the variability. SS patients, homozygous SS patients are more severely ill than SC or S beta plus thalassemia patients, but only somewhat does genotype explain the pain variance and the phenotype variance. Patients express their pain in various ways with inactivity and by emotional expression and crying and even by socially, they may withdraw. They may at the last minute seek relief from opioids or from other things such as heat and massage, their family, their friends. And if all else fails, come to the doctor. So when they come to the doctor, especially for adults, they have given up. They've tried everything they know to try at home. And that's what led us to do this study for which I'm best known, called the Pain and Sickle Cell Epidemiology Study, which showed that unlike what we thought and what the textbook said, which was that all pain in sickle cell disease is treated in the hospital, and when they're not in the hospital, they're not in pain, we showed the opposite. In fact, only 3.5% of days were spent in the hospital or emergency department. Another 13.1% of days, 3 times as many days, were spent at home in what patients called a painful crisis. And then another 40% of days were spent at home in what patients did not call a painful crisis, but was still described as pain. As you can see, the variability and severity was as expected. The most severe pain, and only the most severe pain, led to them coming to the hospital. And pain that was still called a crisis was less severe. And then pain that was not called a crisis was even less severe. This kind of pain leads to tremendous impacts on all of life for patients with sickle cell disease. They have school difficulties. They have treatment adherence difficulties. They have difficulty transitioning from pediatric to adult care. They're isolated. They have poor psychosocial function, depression, anxiety, alcohol abuse, sometimes in an attempt to treat their pain, They have stress, they catastrophize, they somatize, they don't move, they have poor self-efficacy and poor coping. So pain in sickle cell disease, after a while, chronic pain especially, becomes its own disease. And these bidirectional arrows suggest causal inference back and forth between pain and fatigue, depression and anxiety and pain, sleep disruption and pain, stress and pain, and so forth. So all of these are related to one another. Pain is its own disease. And here's some examples. Alcohol abuse at the rate of 31%. Here's the quality of life, showing that patients in the Pisces study, their quality of life was roughly that of dialysis patients. And their response is really what you might expect. This pain is stressing me out, but I really don't want to go to the emergency department. And I catastrophize by saying, oh, this could be the bad crisis. Or if I go, the doctors won't treat me. So all of that influences the decision of whether they actually go for treatment or stay at home. So at the beginning, pain is acute on chronic. It's mostly ischemic and nociceptive, and it's mostly from vaso-occlusion. But eventually, there's phenotype transformation, and Dr. Zemsky and I are studying and wanting to figure out when that happens, but it's somewhere around teenage years. Pain actually transforms via something called brain plasticity and central sensitization, so that you actually have central neuropathic pain. We're trying to understand how to measure that and what are the phenotype transformation mechanisms. How do you even identify it using things like quantitative sensory testing and surveys and imaging. And then how do you treat that once the pain transforms? Obviously, opioids are not the only treatment necessary, but where's the place of biobehavioral treatment, non-opioid analgesia, and even disease-modifying therapy like hydroxyurea and transplant. I think I have a slide that shows you that even transplanting patients does not get rid of their pain always. Pain in sickle cell disease is undertreated. It's the job of the primary care physician, so says Sophie Lanscron, whether that's a hematologist playing the primary care doctor or a family medicine or internist, to treat patients with pain, the general pediatrician, to treat patients with pain. And that's indeed who sees these patients, but they don't feel prepared to manage them. And now we have this mountain of adults because of the wonderful pediatric care you have provided to our patients. You've kept them alive with antibiotics, prophylactic penicillin, and you've kept them alive with immunizations, and you've kept them alive with transfusions to prevent strokes. And now they're adults and they have nowhere to go, and we're not treating them very well. Here's an example of what I said about oncologists. Very few of them are seeing sickle cell patients. The percent that we're seeing 6 or more patients per month was only 8%. 35% of them said, I don't use I use guidelines. That means 65% said they didn't use guidelines to manage sickle cell disease adults. And they don't like to give analgesia. Over concern about addiction is one of the first reasons. I'll come back to some of these others. But the over concern about addiction is the opioid epidemic. And Trump said it was a national emergency in 2017 because here you had opioid overdose trumping motor vehicle accidents as the major cause of death. But look at what's happened. There's been 3 waves of the opioid epidemic, and the latest wave is the fentanyl or semi-synthetic wave. No longer are prescription opioids killing people. Now it's semi-synthetic opioids. And the second wave was heroin, street heroin, good grade street heroin. And so in Virginia and across the United States now, one dose of fentanyl mislabeled as Xanax or as Percocet in a pill is what is killing people. Nevertheless, doctors and nurses think that patients with sickle cell disease, sometimes prescribed opioids by physicians, are addicted. 53% said they were addicted in about 15 years ago. 23% of blood doctors, hematologists said that more than 20% of patients were addicted. Emergency departments, 22% of them and 9% of hematologists believe that greater than half of the patients they treated were addicted. Now, the definition of addiction, it was the problem there. They misunderstood. These patients are tolerant, they're not addicted. And we showed that if you do a vignette study and compare sickle cell patients to chronic pancreatitis and chronic low back pain, that the sickle cell patients are more likely to be labeled as misusers or dependent. The fear of use of opioids and makes people reluctant to prescribe and disbelieve their patients' report of pain severity. And physicians incorrectly look for lab findings, total hemoglobin, the reticulocyte count, anything you can name, the white count, in order to decide whether someone is in a painful crisis or not. There are no objective signs of a painful crisis that you can easily see in the emergency department. This led the New York Times to say, well, you know, we put those 2016 guidelines out and you guys stopped prescribing opioids. Maybe you want to slow your roll. Don't misapply the guideline in such a way that you risk patient health and safety. I'm not sure this was nearly heeded in the way that the 2016 guidelines were actually heeded. And I'm proud to say I was involved in a rewrite of these guidelines to be published at a website near you soon, I hope. So what is prescription opioid misuse? It's use in any way not directed by a doctor without a prescription of one's own in amounts that are greater than should be and in frequencies more often than should be or longer than directed. Here is an estimate of the current misusers, something like 3.8 million people greater than 11 years of age. And there are people who misuse are obviously current or future concurrent use of heroin is a greater risk. So I'm not underplaying the risk, it's there. But is it there for most people with chronic non-cancer pain? Well, here is a statistic that said 32% of patients, not 50, not 100% of patients with chronic non-cancer pain might be misusing their opioids or they're using cocaine or amphetamines. Who were these people? They were young people with past alcohol abuse or past cocaine abuse or past convictions for drug trafficking or driving under the influence. And they were not necessarily the Blacks, the poor, and the uneducated, or the depressed, or the disabled. These were not associated with misuse. They were not the people in the most severe pain. No association with misuse. What is it that sickle cell disease patients are doing to give the impression that they're opioid drug seekers? Well, they're tolerant. The amount that used to work doesn't work anymore. And it may be experienced as, I need more. I need you to give a dose that's twice as much as what you gave me. It scares the doctor. They decide the patient's addicted. It doesn't last as long And the doctor goes, God, that would have killed me. How come it didn't kill this patient? They may even be physically dependent. Now listen close. Physical dependence means that if I stop the drug, I get a withdrawal response. Well, that's going to happen if you give a prescribed opioid for a month, every day, in a laboratory environment or in a treatment environment. No matter how the patient, quote, scores their opioid, if they take it long enough, they will become physically dependent and have withdrawal symptoms upon abrupt discontinuation. That does not mean that they're out seeking the dose, or that they're psychologically dependent, or that they're using it for fun or to cope, or to do anything other than get relief of their pain. So what we see is that if you start having pain with sickle cell disease at age 6 months, and you have it 2-3 times a year, or worse, you have it for more than half of your days, like many of our patients, and you're taking opioids for that, any amount of those days, then even if you're not physically dependent, you're going to be tolerant. The amount that used to work doesn't work for you. And if you take it daily, and then you stop, you're going to be physically dependent. In our experience, the rate of addiction is low in sickle cell disease. What has happened is that the war on opioids has hurt our patients. This is an article that appeared not long after the guidelines were published, saying, a lady called the office on Monday, July the 10th, and told me she took her last pain pill the previous Friday. Her doctor is reviewing her case, and unable to get her meds, she's probably going to end up in the hospital because she needs to go to the emergency room to have her pain treated. Another Virginia advocate said, the pain can be excruciating. 3 times in my life, the pain was so great, I prayed to God to let me die because I didn't think I could stand anymore. At that point, the CVS announced that it would only fill opioid prescriptions for 7 days, and insurer Cigna announced it would not cover OxyContin in the future, but only generics. So we had this panic of trying to curb opioid misuse, but at the same time abandoning our patients who had legitimate needs for opioids. Well, are opioids killing sickle cell patients? I think I alluded to this earlier. No, they're not. In fact, the opioid related mortality rate for sickle cell disease was very, very low compared to the mortality rate for heart disease, fibromyalgia, low back pain, and migraine. The absolute number of patients was 95 who died over a 15-year period, looking at the CDC's own data from opioid-related mortality, out of 12,261 total sickle cell deaths. And if you look at fibromyalgia, it was 4.4%. If you look at migraine, it was 4.5%. So for most people, the death rate from opioids in the non-cancer pain category was higher than that for sickle cell disease. This is just showing that it's not a problem with inpatient deaths. The rates declined annually by 9.9%, and there was a 350% increase in non-sickle cell disease opioid-related mortality. And the point here is that it's compared to non-sickle cell patients, opioid-related mortality might have gone up, but not so for sickle cell patients. What about lack of knowledge of pharmacology? Most people don't understand that sickle cell pharmacology, sickle cell analgesic pharmacology is important to use in the treatment of pain. This is the Pisces data set, and most people were treated with either short-acting or non-opioid or no analgesics. And only the most severe patients were given long-acting analgesics. And they happen to be the patients that had the most intense pain. So this reminds you of the opioid analgesic ladder suggested by the World Health Organization low 30 years ago for cancer patients. It looks like that's the way opioids are being used in sickle cell disease. So the pain intensity was higher, the frequency was higher in the patients who got the most intense treatment. By the way, going to the emergency department more often is not associated with using more opioids in patients with sickle cell disease. So you can't say that it's the people, those frequent flyers we call them. It's not the frequent flyers that are getting the most opioids necessarily. All right, what about poor pain measurement? And that is where a lot of our problem occurs. Pain is more difficult to measure than we'd like it to be. Dr. Zemsky and I served on a pain measurement panel called the Phoenix Toolkit group, and we came up with our best estimates of how to measure pain. But even those have their drawbacks and their gaps. In the best of all worlds, a patient should have their pain phenotyped, the impact of their pain measured, and you should have some very good tools to help you decide on a personalized treatment regimen, individualized for that patient, using any number of modalities, not just opioids, but also non-opioids, disease-modifying therapies, including transfusion, transplant, hydroxyurea, gene therapy even. Immunomodulatory drugs that are out now, no time to talk about all of them. Complementary and alternative measures, including CBT and mindfulness medication, acupuncture. And Dr. Zemsky will tell you that only in the best places, like Connecticut, for the children, and I'm not sure if they have this for the adults, are there clinics where people will get these things and not have payment being a barrier. This is just fresh off the press, just published in the journal called Pain. Here is a shorthand way of phenotyping patients according to their pain variability and their pain frequency. My colleague Nitya Bakshi and I used the Pisces data set to come up with 3 clusters. And I won't bother going through the 3 clusters, but they're basically people who don't have a lot of pain, people who vary a whole lot in their pain from day to day, and people who are just what I call in a constant drone. They just hurt all the time. And we see this anecdotally in our patients. And I can sort of tell you, even without a pain diary, where my patients fit in these categories. And I think it might be a useful way to start trying to phenotype patients and decide on treatment regimens for them. Okay, what about poor role models as a cause for inadequate analgesia? Once again, it's the primary care docs who are, quote, stuck, unquote, with the job of treating pain and sickle cell disease. And if you have kept up with opiophobia in the news since the 2016 CDC guidelines, you know that most primary care doctors are loath to give out opioids, and some have put up signs in their office saying, no opioids given here. So we have a problem in that the need to be willing docs are not willing. And the patients also sense that and are sent off to pain management clinics, and in pain management clinics are fired shortly because they don't, quote, adhere to the protocol, end quote. So these patients are stigmatized, disbelieved. They have symptoms that are difficult to explain. The healthcare system is often hostile to them. They're underprescribed opioids. They're suspected of diversion. Providers don't actually know how to treat them, so they throw up their hands. And then there's disparities for funding and research. And then there's this two-way war that breaks out, interpersonal war that breaks out, especially in the emergency department. The patient has the audacity to request more pain medication or a specific dose. They get admitted to the hospital. They come back over and over. This term pseudo-addiction, which is behaviors that are called addiction when in fact they're just appropriate relief-seeking behaviors. And then communication barriers occur. Trust is broken. The patient loses trust in the provider has no trust for the patient has a negative experience, they don't want to come back, they wait to come back, and when they come back, they're in worse shape than they were if they had gone earlier. So it's a vicious cycle. And that has led to the typical thing. Dr. Smith, I don't want to go down to that parenthesis. Loud, long waiting, hostile emergency department to get my pain medicine. I really won't go unless you make me go. And then when they go, yeah, just like I thought, I didn't get treated right. They didn't put me back in the back immediately. And then disputes even break out. I gave you a dose of pain medicine last night, and I gave you a dose tonight. Go home. And the patient goes, I'm not out of pain. Well, you're addicted. And then, how dare you call me addicted? I mean, these things are actually documented in the literature. There's actually scales now. There's so much of this going on. There's scales to measure trust and scales to measure stigma for sickle cell patients. So we have a difficult time. The solutions. Health equity is the solution. How do we achieve health equity? We certainly got to start at individual levels, but we also have to work at a social level and a community level and at a provider level, and even training organizations and institutions, not to be insensitive, not to stigmatize, not to make assumptions that are wrong based on either folklore or misperception of patients' communications. Not a small task, but we need to do this or else we will not get past the current mess that pain treatment in sickle cell disease finds itself in. Of course, we need to find non-opioid solutions. Nobody wants to give opioids as a first wave of therapy if they can help it. And even the patients will tell you they don't want opioids as a first wave of therapy if they can help it. But if it's the only thing that's working, then they're going to ask you. I got some help from this warrior who went to the state attorney general and got a regulation passed to give us safe harbor in the state of Virginia for prescribing higher levels of opioids than the CDC recommended without having to forcibly justify it. In other words, they put us in the same category as cancer and terminal care conditions in terms of what we could do for prescribing opioids. That has given me a lot of relief, not gotten me out of trouble with pharmacists or even with CVS for that matter, or even with my own hospital for that matter. But I think what it has done is said it's not right to withhold opioids from patients who need it. And sickle cell patients is a group of patients who need it. let me stop, take some questions and some comments. Thank you for your time.
Thank you, Wally. That was really wonderful. I want to start with just a comment because obviously Wally's experience and work is in the adult sickle cell world, and but just in his Pisces data regarding the incidence of chronic pain in adults with sickle cell disease demonstrated about almost 50% of patients at least had a good deal of pain. When we look at our sickle cell clinic here, and I would wager to guess this is true across the US and Canada, up to about 30% of adolescents with sickle cell disease have evidence of chronic pain. So these are challenges. These patients don't just all of a sudden when they hit adulthood develop chronic pain. This is emerging in adolescence. And so we need to, in my opinion, really develop strategies to minimize the development of chronic pain in youth, because these youth with sickle cell disease become adults with sickle cell disease. The other thing, while I didn't mention, but the highest risk time for adverse outcome is really in the transition from pediatric care to adult care, partly because in many areas of the country, there's not good adult care for individuals with sickle cell disease. So they're cast out in a world where they don't have the expertise to care for them. So that's again, our duty is to provide the appropriate transition and make sure these patients are getting what they need as they transition from pediatrics to adult. So I'm going to, Lewis, you asked a question, Wally, and I'm going to give this out to you. As these three phenotypes still there when treating with sickle cell disease modifying therapy and complementary therapy? In other words, can people shift from one phenotype of sickle cell disease pain to another?
Yes, I'd like to join that trial. He just designed a trial. So, that 6-month period of Pisces was in 2001 when there was nothing out there. And so those phenotypes we mentioned are from the 2001 era. And you could call it a natural history study. There was some hydroxyurea being given during that period of time. So you could say, yeah, hydroxyurea, in the early hydroxyurea era, it was true. But I have no idea now. We're further along in the late hydroxyurea era, and we have 3 other disease-modifying agents, and we have transplant, and we have gene therapy, and it would be worth a trial to see if that is true.
Yeah, I would add, I think, we'll understand more of this as we move forward, but I think, again, I'll get back to my point. It's easier to prevent chronic pain from developing than it will be to treat it once it's developed. And that's where I think, and for those who aren't aware and don't do this every day, there are a number of different new pharmaceutical interventions, in fact, that are hopefully going to change the trajectory of youth with sickle cell disease, but also, again, getting back to CBT, physical therapy, acupuncture, all the other modalities that we know may be effective. We need to get our patients access to those therapies. Please put any other questions in chat. I have one for Wally because I know this is of interest to the pediatric audience, because pediatricians or pediatric pain folks felt we got left out of the CDC guidelines as well. And so you mentioned that you've been involved in an update. Wally, can you give us a little peek into what that's going to look like?
Well, I have to be careful. What I can say is that you don't have to worry if you have sickle cell disease about the update. How's that?
If that's enough, if that's as much as we can squeeze out of you, I guess we'll take it, and we'll have to look forward. When do you think that will be out? Do you have an idea?
I think it's probably in the review stage at CDC right now.
Great. Liz Hansen asked, I'm a pediatric anesthesiologist who does inpatient pediatric pain, struggle to find a good way to help patients who are on high dose opioids during an acute pain crisis. We start to see what looks like transition from sickle cell vaso-occlusive pain to opioid-induced hypoalgesia. Do you have any advice on what we can do to stop making the situation worse?
So is this in the chat? Let me read it again. That was a long.
That's in the chat from Liz.
Yeah, I see it. I got it. Right. So this is someone who likely, I'm going to go out on a limb, likely did not have their opioids titrated up aggressively on day 1, 2, and 3 of their hospital stay to get on top of their pain, and then likely stayed in the hospital far too long thereafter, got into this vicious cycle of central and nociceptive pain. Wind up is the term that some people use. And then you've just got this mess because now they're stressed out, which leads to more pain, and they don't trust you, and you start to doubt their report. The best, just repeating what you said, Dr. Zemsky, an ounce of prevention is worth a pound of cure. Day 1 of the hospital stay is the time to try to prevent this. Now, once they get into that situation and they're saying, I don't want to go home, or my pain is still a 10, and how can you stop my PCA? Once they get into that, it's a matter of negotiation, because maybe somebody says that the goal for that person is to have them at a 0. Maybe somebody else says, no, the goal is to have them down to a level where they can go home, which is what I think, to have them at a level where they can go home. And glumming on to the next question, ketamine does have a place there, in my opinion, as a tool to try to help people decrease their opioid consumption so that they can go home. I don't have as much experience with lidocaine. I know about lidocaine, but ketamine does have a place when you're already at day 6, day 7 of hospital stay, maybe even day 5 of the hospital stay. But I want to emphasize that aggressive titration on day 1 of opioids to get on top of their pain is the most efficacious way to try to avoid this situation. Sometimes we start out afraid we're going to overdose the patient, so we don't aggressively titrate at the beginning, and they just go on and on and on for 2-3 days, writhing in pain and still in 10 out of 10 pain. And in my mind, you lost the battle if that happens.
Yeah, and I would add, regarding ketamine and lidocaine. So I was part of the ASH pain guidelines, American Society of Hematology guidelines, that came out last year. And we did put in a provisional recommendation for ketamine. We didn't feel like there was enough evidence for lidocaine yet. So in fact, we just, at my place, we just finished rewriting our guidelines to really try to use ketamine earlier in the course. And it gets to this same concept that if you wait 5 or 6 days into a hospitalization to use something else, you've probably lost that battle too. So we've tried to really look at using ketamine earlier. So if within 24 hours, a patient really hasn't started to turn around, we're going to try to front load the use of ketamine a little bit more. The esteemed Dr. Walco asks, is there anything that makes patients with sickle cell disease at greater risk for chronic pain than others who have poorly treated pain over time?
Wow, what a great question. We cannot find a biological risk factor at this point that predicts the development of the chronic pain phenotype, say by the age of 20. Everybody wants to know that question. And the best study to design, best design study to answer that question would be one that phenotypes patients early on, say 6, 8 years of age, deep phenotypes of those patients, and then simply follows them forward in time for several years to answer the question, is there something that we could use to say, oh, that one's going to go on to get chronic pain, and this one is not.
So I'm just gonna, I read in it, Kalpana Gupta, Wally, has published some stuff. This relates specifically to patients with sickle cell disease versus patients without and their development of chronic pain, that free heme, so patients with sickle cell disease have hemolysis and there's free heme, and free heme actually may be a contributor to sensitization. So there may, this is in a mouse model, but there may be something there that does put individuals with sickle cell disease at higher risk besides all the other things that are going on. So I guess we'll need to learn more about that.
Yeah, and I would agree that they, as a category, the patients with sickle cell disease are at high risk. But to me, the interesting question is which sickle cell patients need an intervention early on to prevent them from going on to chronic pain, and which ones can you say, oh, they're safe? Yeah. That to me is just the burning question that everybody wants to have answered. Mm-hmm. Of course, if you go with that heme hypothesis, then that just says disease modifiers need to be aggressively used. Mm-hmm. What's the best disease modifier we've got? It's hydroxyurea. So I'm a huge hydroxyurea fan. And I would say that is like first line therapy for trying to prevent any sort of downstream complications of sickle cell disease. And certainly now we have some evidence that it actually prolongs life.
Mm-hmm. And that's exactly what your colleague, Dr. Sue, added into the chat. So Katie asks, how can we emphasize the importance of chronic pain clinics and integrative modalities for adolescent sickle cell disease patients who are resistant and believe you to be withholding opioids, not believing their pain?
Yeah. So they don't trust us, and I'm including Wally Smith in the us. It's not just about race. It is somewhat about race, but it's not just about race. So, I'm from the country, so the devil you know is better than the devil you don't. In other words, if you're comfortable with a modality of treatment and somebody implies they're going to take that modality away from you, no matter how ineffective that modality is overall, it's the modality you know. And that's what we're offering people. We're offering them something new and strange that they never tried before. I had someone beg me today to not get a hip injection for their avascular necrosis. Please don't do that to me. And I thought, really? You don't want me to try to relieve your pain with a hip injection? Well, what they really meant was, please don't take my opioids away. They were definitely afraid that if they got the hip injection, I'd say, okay, you don't need any opioids anymore. But they couldn't bring themselves to say that. So it's a trust issue. And when I figure that out, I'll get back to you.
All right. Paula asks, transition issues have been found for chronic pain patients as well that includes dropping out of post-secondary education. How can we partner to improve transition for adolescents with chronically painful conditions?
Yeah. Well, I think that one of the first things we can do is establish systems of care. This is a systems issue. I showed you that slide that talked about institutional interventions. Mm-hmm. This is a systems issue. We have very poor systems of care in the United States. We have an illness healthcare system, not a preventive healthcare system. We have a fee-for-service, not a value-based system. And we have a money-making rather than money-saving healthcare system.
Well, I'm from Canada, and so we have a different healthcare system, but we still have issues. And I wonder if it goes to the societal level of, I really believe that pain is a social phenomena, in that how society thinks of pain is why so many people continue to suffer. And so I think, it, these issues are like, when I heard you talk, and thank you, it was wonderful. It mirrors a lot of what we've heard over the years of all kids with chronic pain and people with chronic pain, but to such a even more significant degree because of race. And so I just think that we need to, how do we, and it's something we all grapple with, is also change society.
Yeah. Yeah, well, thank you for saying that, because everybody looks to Canada with awe and adoration, that if only we move to Canada, it'll all be fine.
Oh, some of it is. I mean, at least they have access to some of the treatments that Katie was referring to. Not, but it's not, society's not perfect anywhere.
I think that's a great place to stop. We're right approaching 1 o'clock. And I just want to thank Wally and our audience. This was a great discussion, gives us a lot of areas to think about and to work towards. So I always want us to leave these events thinking how we can change our own individual environments to do a better job. And let's all give Wally a little virtual clap. And we'll look forward to those renewed CDC guidelines. Thanks very much, Wally.
Thank you so much.